Hello, my name is Caitlin Kelly, and my partner is Carly Stevens, and today we will be presenting on the article, New Onset of Ocular Myasthenia Gravis in a Patient with COVID-19, a Novel Case Report and Literature Review. Over the course of this presentation, we hope that you learn and can apply these 3 learning outcomes. So first, let's discuss what myasthenia gravis is. Myasthenia gravis is a disease that is characterized by weakness and fatigue of skeletal muscles. In most cases of the disorder, the pathology is caused by autoimmunity. More specifically, autoantibodies will attack acetylcholine receptors at the neuromuscular junction, which is the synapse between a motor nerve and a skeletal muscle. And because acetylcholine is a crucial neurotransmitter that really enables the communication between nerves and muscles, the autoimmune attacks typically do result in a lot of muscle weakness. Since the start of the COVID-19 pandemic, scientists have worked towards gathering more information on the virus's effects with regard to individuals. Through analysis of novel case reports, researchers are finding that COVID-19, again and again, has neurological manifestations. These previous studies have indicated that infectious agents can sometimes worsen myasthenia gravis symptoms in patients already with this disorder, and other studies have shown that coronaviruses like SARS and MERS have previously caused pathology in both muscles and neural tissues. Thus, the goal of this study was to analyze the first patient case in which a COVID-19 infection could have potentially brought on a neurological disorder such as myasthenia gravis in the body. The patient in this case was a 65-year-old woman who had many prior medical issues unrelated to COVID or myasthenia gravis, with her most recent operation being her partial nephrectomy or removal of her kidney. For 2 weeks before the study, she presented with mild to moderate COVID-19 symptoms that are listed here. When the patient was further analyzed by the researchers in the study, they found that she had inflammatory markers that were summarized in the table. In further examination of her, they also found she had symptoms that resembled those to myasthenia gravis patients. She had ptosis or drooping in her left eye, some diplopia or seeing double images, and even some weakness with closing her eye. So after recognizing this, the researchers ran a series of tests to determine whether or not she actually had myasthenia gravis. The first test they ran was an EMG exam, which assesses the health of her muscles and motor neurons by stimulating them with electric shocks. In their series of 4 electric shocks, which were administered to her left orbicularis oculi muscle, the patient showed a decremental response of greater than 10%. In other words, the patient had a smaller and smaller response with each successive shock.
Upon the initial diagnosis of myasthenia gravis, there were 3 big indicators that pointed toward the disease. The first indicator is the results from the EMG test. Secondly, an ice pack test was positive for MG. To perform this test, one places an ice pack on the patient's eye and observes any noticeable deduction in swelling. If swelling doesn't decrease, signs point to MG or similar diagnoses. The third indicator is antibodies against P, Q, and N-type calcium channels. With these symptoms, the patient was diagnosed with ocular myasthenia gravis in the left eye. Following the initial diagnosis, the patient was discharged on 60 milligrams of pyridostigmine. There was improvement of diplopia and ptosis. However, the patient was still positive for COVID-19 upon discharge and still experienced mild symptoms. She was hospitalized again due to more severe COVID symptoms, and they found residual MG symptoms still remained. According to the case report, the patient was not predisposed to MG or other neurological complications. However, she had neuromuscular manifestations 2 weeks after COVID-19 predominant symptoms. This paper also reviews 17 other patients who were diagnosed with MG before catching COVID-19. Our case report was significant in comparison to these patients because of it being the first potentially COVID-induced MG case. Now, let's discuss how MG can potentially be induced by viral infection. Disclaimer, this has not been a proven mechanism. COVID-19 has affinity for angiotensin converting enzyme 2 receptors, or ACE2 receptors, which are on the cell membrane. These can form autoantibodies in an inflammatory cascade. Using ACE2 receptors, COVID-19 has the ability to produce cytokines and chemokines, decrease B and T cells, and increase levels of interleukins and TNF-A. This overall can cause an autoimmune attack on our own body's receptors, like acetylcholine receptors in the case of MG. Furthermore, there have been associations between other infections and the development of MG. Post-infectious MG has also been provoked by varicella zoster, West Nile, and Zika virus infections. This is what led to the investigation of whether COVID-19 can induce MG similar to these other viruses. In summary, the case report is about a 65-year-old woman with moderate COVID-19 symptoms and myasthenia gravis in the left orbicularis oculi muscle. In comparison to other cases, this is significant because it's the first reported case of ocular MG most likely induced by COVID-19. Other infectious agents are also known to be associated with stimulating MG autoimmune response. In conclusion, COVID-19 has proven to lead to neurological complications. However, it is unclear whether COVID-19 can generate antibodies against neuromuscular junctions, just as it does in MG.
Thank you so much for listening to this presentation.